Hello, today we'll be presenting our teenage pregnancy prevention program. Alongside me was Susanna, Catherine, Aaron, and Quang, and I am Aiden. An overview of the program. First and foremost, we're targeting teenage pregnancy prevention. Our target population characteristics encompass Hispanic female teens with the age range of 15 to 19 years old. We are targeting Canatillo and Burgess High School in El Paso, Texas. And lastly, our target prevention is primary prevention.
Justification of the program, morbidity data. In 2020, Hispanic teens have the highest birth rates, 32.3 per 1,000 girls in any other race or ethnicity. According to Texas Department of Health Service, total Texas live births in 2020 among teens aged 15 through 17 were Hispanics. Hispanics had a total of 4,304 births. Non-Hispanic Black had a total of 774 births. Non-Hispanic White, 840. Non-Hispanic Other, 152. Teens aged 18 through 19, Hispanics, had a total of 10,782 births. Non-Hispanic Black, 2,184. Non-Hispanic White, 3,181 births. Non-Hispanic Other, 422. Compared to our El Paso, our target population, teens aged 15 through 17, Hispanics had a total of 207 births, and then non-Hispanic, Black, White, and others, there was no data reported. And then teens aged 18 through 19, there was a total, for Hispanics, there was a total of 557 births. Non-Hispanic Black, there was 16. Non-Hispanic White, and there's 38. And non-Hispanic Other, no data reported. Some of the risk factors were low-income households contribute to teen pregnancy, and El Paso, 20.1% of households are in poverty, and about 82.9% of the population is Hispanic. So most of the people who are in poverty are Hispanics. And according to Texas Department of Health Service, Texas Healthy Mother Babies data book, about every teen in Texas are at risk of preterm birth. Overall, Texas teen pregnancy rate is high compared to other states. That's why we chose to focus our program there. We chose to count El Paso because the population is majority Hispanic, and that population has the highest birth rate based on data. Now for the population mortality data. In 2020, there is no death caused by complications of pregnancy or childbirth among teen mothers in Texas. The leading cause of infant deaths in Texas was birth defects in all populations. About 32.2% of mortality was among Hispanic infants. According to CDC Wonder database, the total infant mortality in Hispanic subgroups from teen mothers aged 15 through 19 were Mexican. There were 79 infant deaths. Central or South America, there was 12 deaths. Other and unknown Hispanics, 21 infant deaths. Non-Hispanic other race, 67 infant deaths. So the last time El Paso reported infant mortality from teen mothers was in 2013. And that was from Mexican mothers. And there was 10 total of infant mortality. Since then, there was no infant deaths reported so far.
According to the CDC, there is an association between the teen pregnancy and the increase in the reliance on the health services. With the $1.9 billion in the increase of public health care costs, 2.2 increase in the child welfare costs, and $2.1 billion for the state prison system, mostly among the adult sons of teen mothers. Data also show that $2.9 billion also lost in tax revenue due to the lower tax being paid by the children of teen mothers. Teenagers' mothers in education are less likely to receive a high school diploma, while more likely to live in poverty. The children of teen mothers are more likely to have a lower school achievement and a higher dropout rates.
Our behavior model description is the theory of planned behavior. Essentially, it suggests that intentions, attitudes, and subjective norms influences individuals' behavior. The first component is attitudes. Attitudes are a set of beliefs and feelings directed towards an idea, person, or object that may affect the way a person will behave. Component two are subjective norms, which refer to whether or not an individual views a certain behavior as acceptable or unacceptable in society or societal influences such as friends and family. Component three is perceived behavior control, which refers to one's own belief that he or she or they is capable of doing a certain action or behavior. Lastly, component four is behavioral intention. It is a measurement of an individual's motivation to perform a particular behavior.
This is a good model for our program because it gives us the opportunity to shape the way that teens perceive the risks of teenage pregnancy, as well as their attitudes and beliefs toward using safe-sex methods such as condoms or birth control. In this case, our goal is to reduce the chances of pregnancy by targeting these four components of behavior. And the activities that are required to achieve our desired outcomes include the participation of sexual education courses, communication with healthcare services, and sexual advisory courses to inform our program attendees. And that can be done through workshops, through, as I mentioned, sex education courses, but we'll be going into that more when we link it to our logic model. And so the chosen behavior model is suitable given that with application, we can predict what our target population may commit and counteract their actions with a positive learning environment and associations with safe sex methods.
For the description of our logic model, for inputs, we put financial funding, healthcare professionals to teach the information, after-school program time, space, and location, and program/learning materials for the people that attend. For activities, we have a safe sex course that provides types of information on practices of contraceptives, provides information on other possible risk factors associated with unsafe sex, including unplanned pregnancy and STIs. We have a sexual education course that explains the male and female reproductive systems, a healthcare services where services and questions associated with personal health are available to the students, and growing communication skills with parents, professionals, and with your partner during sex. And we have a parenting workshop for communicating responsibilities of future parents, including the financial aspect and just other responsibilities. For outputs that relate directly to our impact objectives, we have participants will have increased knowledge of contraceptives and their effectiveness. Participants are educated on the effects of unprotected sex, and participants are educated on available health services.
So now I'll be linking our behavioral model to our logic model. So the first component from our behavioral model was attitudes, and we decided to shape students' attitudes by having after-school programs which include educational staff and sex ed professionals to further educate students about safe sex. And when I talk about safe sex, we mean educating them about different contraceptive methods for them to practice safe sex and to decrease the likelihood of teenagers becoming pregnant. So for the contraceptive methods, we'll educate them about birth control, condoms, and education about menstrual cycles and ovulation. And we'll talk about ovulation just because that's when a woman is more likely to be pregnant if she engages in any sexual activity. And so that's why we'll be talking about that. And for this after school program, it will be 1 hour sessions twice a week, probably Mondays and Wednesdays for about an hour. And that will be going on for about 6 weeks. So that's about 12 sessions in total. And in these after-school programs, there will also be sex ed professionals, as I mentioned before, and they'll be shaping students to have more positive attitudes towards the use of contraceptives to increase the likelihood of the use of protection and contraceptives. And another way to shape students' attitudes to have a more positive mindset towards a particular behavior is by having professionals discuss their experiences firsthand dealing with teenage parents and how it affected their lives, and not only their lives, but their infants as well, because there can be many complications with that. So yeah, and then for component 2, which was subjective norms, we decided to enforce mandatory workshops where all students must attend to receive credit. And for these workshops, students, to receive full credit, students must attend at least 3 a semester. And in these workshops, it will involve school administrators along with medical staff to discuss risk factors of teenage pregnancy. So discuss the finances, the medical bills, the bills to help pay for everything for the baby, such as diapers, food, housing, and everything. Again, we're talking about Hispanic teens who come from low socioeconomic status, so it's important to discuss all the finances that comes with it, along with maternal complications and infections that women may get during their pregnancy. And then as well as deaths and complications among the infants as well. So there's a bunch of risk factors that come with it, and educating students about this in these mandatory workshops would definitely help decrease the likelihood of teenage pregnancy as well. So overall, they'll have an understanding of the use of contraceptives for preventative measures, as well as the risk factors that come with teenage pregnancy.
The component 3, perceived behavior control, explain how students understand that it is important to use control when engaged in sexual behaviors to prevent pregnancy. They are not willing or cannot engage in using protections due to their perceived available resource. By increase the outreach of sexual education course and healthcare service, it can increase the likelihood of sexually active teenagers to be more aware of the services that are available to them. This can be done through spreading flyers that can contain information on the available resource, and as well as an outreach for the sexual education course. By recruiting students that can work directly communicating with the teachers and the classroom, it can also help spread the info on the available resource, as well as a way to give out the flyers. In learning, professional educators should aim to empower students in the course to use protection by addressing behavior barriers such as perceived partner acceptance upon requesting condom use and the self-efficacy in carrying and using protection.
As for our 3 measurable impact objectives, in June 2025, the experimental group will increase their knowledge of contraception by 40%, as measured at post-test through a self-administered questionnaire, questions 1 through 10. In June 2025, the experimental group will increase their knowledge of the effects of unsafe sex by 30%, as measured at post-test through a self-administered questionnaire, 1 through 12. In June 2025, the experimental group will increase their knowledge of available resources for preventing pregnancy by 45%, as measured at post-test through a self-administered questionnaire, questions 1 through 7. Here are our references, and thank you so much for listening.